My name's Eric Buch from the University of Pretoria. My concern is that this morning's discussion for me has not taken us any further. Ms. Motsoaledi has articulated again the basic case of why we need to advance the health system and the NHI. But we haven't, and many different pieces, including the new hospital strategies and the district program and many other pieces are being put in place, but many of the details are still not coming through of what kind of NHI are we working towards? What will it look like in 5 or 10 years' time so that we can start exploring and understand that better? Our colleagues from the private sector have spoken mostly platitudes about building relationships and their valuable potential role, but have not really tackled the core problems of over-servicing, of why the private hospital sector hasn't, for more than a decade since it started talking about it, been able to offer low-cost private sector options that will be affordable in the NHI, and to deal with those issues. COSATU has been a strong proponent.
Eric, sorry.
This is my last sentence, of the NHI, but is not articulating what kind of NHI it would like to see emerge. And I think if we want to take the discourse forward in a strategic way with the kind of strategic health minds and health leaders here and explore that way, I think we need to start moving the discourse on the NHI to the next level.
The first question by Professor Eric Buch, he's correct, 100% correct. But there's no way of doing what he's asking us to do in 20 minutes. You need the whole day's workshop. And because I'm the accused here, it's just fair to be given time. We have worked up all those issues you're talking about. I can show you what is that which you are planning for the first 5 years in detail, because we have got it even on slide. That this is what will happen. I can show you what is that which must happen in all the 10 pilot districts this year. It's detailed. It's not something that we're just dreaming about. I don't understand why people believe we could put such details on a green paper. A green paper is a policy document. It's not an implementation document. And people keep on saying, no, we don't have this on a green paper. You can't put such details with dates and time frames and weeks and all that. No green paper looks like that. But having said so you need a whole day, and I'm available for that, by the way, because this is a very important revolution. You can't just do a revolution in a wishy-washy way. I'm prepared to spend the whole day with you. Having said so, let me just point the first thing, please, which when Dr. Archer was speaking here, you said, was a little bit jittery. I wanted to answer and all that. Let me tell what was making me jittery. Because we said this in 2009, I'm disappointed that it's been said again 3 years later. NHI is not a comparison between public and private. It's not a competition, it's not a war between public and private. And in the organization I belong to, we have never said anything about doing away with private healthcare and saying it's useless or it's not serving us very well or not. We have never said that. And it's not a competition. Please, it's not a comparison. NHI is a constitutional issue. The fact that we are doing it 18 years later doesn't necessarily mean it's not in the Constitution. It's there is Section 27 of the Constitution, and we are implementing it. And South Africans like saying we must respect the Constitution, but they choose which parts they want to respect, which favor them. Yes, like the property clause, everybody believes it's sacrosanct, nobody can touch it. But when you talk about other people's rights, like the rights of health, then they say we are destroying the economy. It can't be. It's a constitution. It's not a comparison. We're not comparing. We're not going. There's no country which I know which said there's NHI now away with private health. I don't know any. Even the countries I've shown there on the map, the ones which a lot of green, they've never done that, and we are not about to do that. The second thing which people forget, which I said when we launched the document on the 12th of August last year, I said there are 2 preconditions under which NHI will survive. And I still stand by that. I'll keep on repeating it. I've repeated it over the radios in the past week or so. 2 preconditions. The first is that the quality of care in the public healthcare system, it has to change. We have to overhaul it. And I said it's non-negotiable. And if you go and check on the plans, the first 5 years of NHI is actually to do that. Bring back the quality in terms of infrastructure, management, financing, everything. And I said that's not negotiable, not going to negotiate, it must happen. And that's what the first 5 years is all about. The second precondition, that's where we are going to argue. And please understand that I won't back down on this one, is the pricing in the private health care. I said it's exorbitant, and that's true. We can't run away from it. We need to look at it. We can't keep on dodging. And it was not like that before. A decade or so ago, it was not like that, and it's a fact. We've got graphs to show that, and I said we need to look into it. And that's why I said we need to look at something like a pricing commission. That is not an attack on anybody. Where is Stavros? Yes. When the World Health Organization, WHO, the Clinton Foundation, and the UNAIDS, when they stood on a public platform and say South Africa is paying more for ARVs than any country, you need to reduce the prices. It was not an attack on the pharmaceutical sector. And we worked with them. Of course, they wouldn't necessarily agree. Money is money. But we worked with them and we reduced the prices of ARVs South Africa was paying for by 53%. We did that. It's not that we hated private pharmaceutical companies. We're just saying this is too much for the country. We can't afford it. We are saying the same thing for private health care, that the majority of citizens cannot afford it. And that's all I'm saying about private health care. There's no argument about its value, its quality and all that. You can't argue about that. We know there is a lot of quality. It's valuable to the rest of the population. But we're saying it's unaffordable. We want it to be affordable. And the second thing we're saying about it also is that it's not a primary platform for healthcare provisioning for all South Africans. It's for a selected few and it will remain like that. You can't argue against that. It's like that all over the world. That's only what I'm saying. And so if the public doesn't work, we are making private healthcare a public platform. It's like I had an argument. One of the people who didn't agree with me is Eric there. And I know he'll keep on pushing that argument. I don't know whether I will eventually agree with other about the training of nurses. I argued that the policy position which was established in 1984 of making universities a primary platform for training of nurses is wrong. Doesn't mean I undermine universities or nurses must go to university. I said it can't be a primary training platform. The primary training platform must be nursing colleges, and a few will go to universities. Same thing as private healthcare, it will be a few. Even now, the CEO of NHS, the previous CEO, was telling me that the Queen in England uses the NHS. But in some instances, when she believes it's necessary, she goes private. But she still uses NHS. But there are times when she say, I'm going private now, and I'm going to pay there, and, I'm not going to NHS. And she's allowed to do that. And we are going to do that in South Africa. But it cannot be primary. What I was showing there, which is true, by the way, Dr. Matlala, when we argue this, there must not be holy cows. It is true that because public health care is collapsing in Africa, health care is being privatized. For poor African countries, it's a fact. And I warn my ministers that you can't go in that direction. I know, and let me not name your organizations, they want to go full-time in Africa and say, no, you can't run away from providing public health care for your citizens and say the private hospital must take over that role. They can't, and they shouldn't. That role belongs to government. And a few of your citizens who can afford, who can make it, will go private. That is my war with the African continent. And I said that at the meeting of the World Health Organization Africa region in Equatorial, in Ivory Coast in August last year, because they were running away from providing health care. What about all these many African leaders who are leaving their countries coming to get health care here and leaving the masses there begging their countries? Why should we keep quiet about that? It's wrong. And we too in this country, providing health care and leaving the masses and going to get our corner there and say we'll pay for it. To hell with the masses. We can't do that. So these are the things that I want to put on the table. So two things. If we improve the quality of health care in the public health and we regulate the price in private health care, then we've arrived where we want to arrive. No more arguments. Thank you.
Thanks, Eric, for your comment, because it actually comes to what I was going to continue to talk about when the moderator stopped me. In our input to the Green Paper, when we were looking at the role of private healthcare in South Africa, we said that we think that the South African private healthcare is actually essential to the successful implementation of universal coverage. And the reason we say that is because, okay, 14 years has been given in terms of the implementation of the NHI, but the minister has just confirmed it to us today to say that the private sector will almost always be there. Now, the biggest problem that we have had with the medical aids, maybe not in the size that it is, yes. But then the biggest problems that we have had when the NHI discussions started in this country is that a project that the Council of Medical Schemes spent so much time on and money on, the risk equalization fund process was almost put on the back bench. But I'm happy about that because now there's a new committee that has been established, and I got this from the CEO of the CMS called RETEMP, which means that that risk equalization, whose aim is to make this process efficient, is probably going to be or is being re-looked at. So as far as we are concerned, in terms of limbs, for example, you cannot, until you deal with things like risk equalization, it's not going to be easy to come up with low-cost medical schemes. Actually, it is for those health economists who do research in this area, they do say that the absence of a risk equalization fund probably increases the cost of medical aids by up to 30%. This is the people who do research there. Now, the other thing that was corrected by the minister here is that healthcare in South Africa is not expensive. It is unaffordable. There's a difference between these two terms. The Monitor report, which is an international report that puts South Africa's private healthcare at 5th in the world, has said that the cost of providing that healthcare, which is classified as 5th in the world, is actually about the 20th in terms of cost. So we provide the same healthcare much cheaper than 20 other countries or 19 other countries. So you realize that why is it that people from the West, be it America, be it Western Europe, do come here for procedures and they don't find it, and they actually pay more than what the medical aids are paying. So that for us is an indication that there are other problems. Poverty in our country, we mentioned. So it is true that you cannot continue flaunting, let's say, your riches when next to you people can't even have supper. Thank you.